Euphlides, and I'm the Senior Director of Wright Medical's Total Ankle Marketing Program. We are very excited to have you all here to discuss the latest innovation in the total ankle segment. That's Infinity with Adaptus. This system will be going into full commercial launch this month. So the incorporation of this new Adaptis technology has really been in the works for over 10 years. And through some recent advancements in manufacturing technology, a lot of hard work across the globe, we are very thrilled to provide you with the market's first 3D printed total ankle system. So during tonight's webinar, our surgeon faculty will walk you through the various enhancements that come along with Infinity with Adaptus. Some of those include it being designed for optimized for bone ingrowth. Additionally, it is increased initial implant stability, and with the incorporation of Everlast highly cross-linked polyethylene, it has improved wear resistance. So along with that, our faculty will also provide some detailed commentary around the role of porous metals in orthopedics, as well as share some of their early experiences with this new prosthesis. So we are very fortunate to have two highly experienced total ankle surgeons with us tonight as faculty and presenters. As our first presenter, we are fortunate to have with us tonight Dr. Robert Anderson from Bellin Health Titletown Sports Medicine and Orthopedics in Green Bay, Wisconsin. So Dr. Anderson is the founding orthopedic surgeon for the O.L. Miller Foot and Ankle Institute of Ortho Carolina in Charlotte, North Carolina. He served as team orthopedist to the Carolina Panthers from 2000 to 2017, and now is an associate team physician to the Green Bay Packers. He has also served as the chairman of the Foot and Ankle Subcommittee for the NFL since 2003, and was recently named the co-chair of the NFL's Musculoskeletal Committee. Dr. Anderson is a past president of the AOFAS, co-editor of the 9th edition of Man's Surgery of the Foot and Ankle, former editor-in-chief of the journal Techniques in Foot and Ankle Surgery, associate editor review for JBJS, JAAOS, FAI, AJSM, and numerous other peer-reviewed publications. So, Dr. Anderson, thank you for finding the time to be with us tonight. And our second presenter is Dr. Hodges Davis, who joins us from Ortho Carolina and Charlotte, North Carolina. So Dr. Davis has been in practice for over 30 years, has authored over 160 publications on the topic of foot and ankle surgery. And throughout his career, Dr. Davis has been widely recognized as one of the most experienced thought leaders in the total ankle space, implanting over 850 today. Dr. Davis also happens to be Wright Medical's Chief Medical Officer, and he aids us in the development of new technologies, services, and medical education programs for foot and ankle surgeons across the globe. And so we are glad to have Dr. Davis with us this evening as well. So just a few Zoom housekeeping notes before we get started. So all attendees except the two presenters will have their audio and video muted for the duration of the webinar. There is a Q&A button on the bottom of the screen, which you can use to type questions to our presenters. Our faculty will monitor those as we move along, answering as many as they can before we conclude this evening. And finally, please note that this webinar is being recorded for later use on our Virtual Learning Center website. Again, thanks for joining, and we'll go ahead and turn this over to Dr. Anderson to get us started this evening. Dr. Anderson?
Thank you, Chris, and hello everyone from Green Bay, and it's a true pleasure to be back working with my longtime friend, colleague, and business partner, Hodges, in presenting this webinar to you and outlining some of the new advances with the Infinity Total Ankle Arthroplasty. So without further ado, we'll get into my presentation. Just trying to get the slides to advance here. There we go, and these are my opinions, not necessarily those of Wright Medical, and I'm sure same for Dr. Davis. So I want to present to you my experience utilizing the new Adaptis technology on the already successful Infinity Total Ankle Arthroplasty. I want to thank Murray Penner because many of the slides that I'll show you in regard to the Adaptis technology I adapted from a recent talk that Murray provided in end of July to the sales force of Wright Medical. Now, I've had incredibly great experience with Infinity. We've been doing these since 2010. I was privileged to be part of the design team and the pre-market trials. I've done over 200 Infinity Total Ankle Arthroplasties since. I've only had 4 or 5 revisions of Infinity total ankle arthroplasties. I have used prophecy navigation on all but the first 4 cases that we implanted an Infinity total ankle in. So again, great success, prophecy navigation all but the first 4 cases, and I'm a sort of a chamfer guy. I like the chamfer talus on all cases where there is adequate bone available. So again, if there's not cystic disease, adequate bone stock, I prefer the chamfer on those cases, and that's been my go-to. This is just an example of where I've had great success with the Infinity. This is a high-level, 43-year-old former professional women's soccer player who failed multiple surgeries for an osteochondral lesion in the talus, underwent a calcium phosphate injection. Unfortunately, a lot of volume was placed into the talus, and from that, she developed avascular necrosis of the talus, as well as a persistent osteochondral lesion and cyst of the talar dome. And you go, well, what do you do with this? This is a very high-level athletic individual that now has a difficult to salvage situation. And we did salvage this with the Infinity total ankle arthroplasty. I bone grafted the defect in the talus, and we placed a flat cut talar component with the Infinity tibia. She's now 18 months out and she's pain-free, doing very well. So again, great results that I had with Infinities over the last 10 years. So Infinity works great, but can we make it even better? And that's been a question that our design team, including Dr. Davis, have broached with the engineers at Wright Medical for years. How do we make Infinity even better? And that's where Adaptis Technology comes in with its new features that include the ongoing low profile resurfacing type concept, now with porous ingrowth, a new type of polyethylene implant that is more highly cross-linked, and new talar options as well. And I'll go through all those a little bit later. Our main priority when we're talking about trying to upgrade the Infinity was, how do we get better ingrowth? How do we get immediate stability? And we've always known that biofoam, commercial titanium coating, would be beneficial on the Infinity total ankle implant. We recognize its great potential for enhancing bone ingrowth. We wanted it in 2010, but in 2010, 10 years ago, the technology wasn't there to place biofoam on the Infinity implant. And again, this was one of our in-house memos that we were writing at the time, saying that, listen, we want 2 big design changes on Infinity over the next few years. One is biofoam, the other is prophecy instrumentation. We've had prophecy since that time, and biofoam now is here. It's been 10 years in the making, but now we have our second highest priority that we recognize in 2010. So let me just segue a little bit away from the new Infinity Adaptis total ankle arthroplasty and talk a little bit about why is bone ingrowth important when we start talking about our total ankle implants. Well, you know, just give you a little history here. The first generation of bone ingrowth was actually just a surface treatment, something that provided a rough surface for bone attachment. When I was coming through my residency, we were talking about sintered beads and plasma spray and acid etching. And those were back in the 80s and early 90s. And then the newer trends, though, now we're devising metals that allow for bone ingrowth, not just on a surface, but through an entire device. And most products that have some type of bone ingrowth surface have been developed for implant fixation surfaces, such as that for total joints. But you also see it in spine, craniofacial, dentistry type applications as well. And what's interesting is that nowadays our products that do allow for bone ingrowth, they cut in almost any shape and can be centered onto the underside of a titanium implant substrate. But again, how do we do that? Is technology there to do that with total ankles? We've seen how porous ingrowth fixation has revolutionized hip replacements. Bill Harris in Boston, talked about this years ago about how porous ingrowth revolutionized hip replacement until it came to the femoral stem. And then a quote from the University of Florence by Dr. Matassi: the development of porous metals for osteointegration has revolutionized the field of orthopedics. And really, it's not just total joint reconstruction. The field of orthopedics has seen the benefits of porous ingrowth metals. Now, our newer methods are now changed out. We now know what exact is the ideal porosity of a metal that promotes bone ingrowth. the ideal is somewhere between 50 and 100, but for orthopedic applications, it's usually somewhere around that 400 to 600 size porosity. We know that our metal ingrowth materials work so much better than hydroxyapatite and ceramics. They're just too brittle to work, particularly as we talk about total joints or larger applications. So again, we've seen more recently metallic graft applications for bone voids. Really, in place of structural grafts, we're seeing people use metal now in place of auto or allograft type wedges. And of course, this can be very useful in revision surgery. There's a lot of types of metal available. There's trabecular metals, the so-called titanium, tantalum, and there's the various titanium alloys. There's commercially pure titanium, which is biofoam, which Wright Medical has seen huge advances in over the years and proven success. We'll talk about that in a few minutes. And there's many other types of titanium alloys that can be used with titanium plasma spray over the top, where the roughness will promote bone ingrowth. And then there's even now trabecular metal avascular necrosis type screws that are available in the marketplace. So we've seen a huge surge in how we use porous ingrowth metals in orthopedics, particularly in foot and ankle, over the past several years. Now, biofoam, though, is something that I know very well and have used it for many years. This is constructed of basically commercially pure titanium. It's 60 to 70% fully porous in its construct. And again, it's in that average pore size of 500, which is right where you want to be when you start talking about orthopedic applications, between 400 and 600 microns of porosity. It's got great compressive strength. It's got a modulus very similar to that of trabecular metal, slightly higher coefficient of friction, which helps with initial stability. As we saw when we were using a lot of the biofoam wedges for Evans and cotton applications, that you can place these devices in and they got immediate stability. Their friction coefficient was very high, and amazing how stable they were right off the bat. And they did a good efficacy, just like trabecular metal did, seen through extensive animal testing. This is one of the first biofoam white papers produced out of Rush Presbyterian Hospital. This was an animal study several years back, again, looking at how successful the ingrowth was with the commercially pure titanium that biofoam is, in the animal study here, where they used the metaphyseal canine model and they compared titanium versus sintered beads. 6 weeks in life, looked at histology and found that there was a tremendously better ingrowth on the commercially pure titanium, which biofoam is, than in the sintered beads. So 32% more calcification within the beads themselves. So again, many studies have been done comparing beads to the porous metal, the biofoam porous metal, and even comparing it to trabecular metal, and found that, again, it's very, very similar to trabecular metal and much better than sintered beads when it comes to true bony ingrowth. So we even got so far that we, and Charlotte Hodges and I were part of this study, we actually went and did CT scans of all of our patients who had a biofoam Evans wedge placed for flat foot reconstructive purposes. And this was a study a few years back that we put together. And again, we had 26 patients that we identified. We had 19 with all the CT scans and statistics we needed. Average age was about 56, so older people. We used additional bone graft in 5 patients, and supplemental fixation was used also in 5 patients. But for the vast majority, they did not have supplemental fixation. And what we did, again, we did CT scans on all these people, and we found that there was tremendously good bone ingrowth into that large metal biofoam wedge. Our CT scans showed that all of our patients had some bony ingrowth. Some had partial, some had solid ingrowth. But fortunately, regardless if it was partial or solid, they had no difference in some of the secondary measures that we looked at. We found that the cost of using this metal biofoam wedge was very similar to the cost of allograft, and also reduced OR time. We didn't have to worry about prefabricating the wedges. So at that point in time, and again, this is several years ago, we knew that biofoam was going to be here to stay. It was a very strong metal, one that really had an affinity towards bone ingrowth. And again, how do we put this on our total ankle arthroplasty? This was, again, something that dates us back, that Hodges and I and the design team and the engineers said, listen, we know biofoam works. It works great. We can see these large metal wedges that attracts this bone ingrowth. Now, let's put it on an underside of a tibial or talar component with our total ankle arthroplasty devices currently available. And again, and when I said that we thought about this in 2010, now here we are 2020 and technology has finally caught up. We now have the opportunity to do this. So this is the ADAPTIS technology merging with the Infinity that we've already seen great successes with over the last 10 years. This new ADAPTIS technology includes 3D printed implants, ingrowth surfaces with biofoam. It still has the ability to use your prophecy. We have a new polyethylene upgrade that we'll talk about. We have both the chamfer and the block flat cut talus opportunities, and of course that interchangeable continuum that Wright Medical has been known for with all of its total ankle implants. So what is ADAPTIS technology? Well, again, you got to think of it as a 2020 biofoam. It's a porous 3D printed metal. It can be made in any shape, thickness, of infinite variability. And so really we can do anything we want now with these 3D printed metals and the porous surfaces that we place on them. And you go, why is this important? Well, again, just like Chris said in the introduction, this ADAPTIS technology with the biofoam addition not only improves long-term fixation, so we're seeing that it facilitates bone ingrowth as early as 4 weeks post-op. But again, just like we saw from the biofoam Evans wedges for flat reconstruction, its initial stability is incredible. So you basically put these implants in and you immediately see increased initial implant stability because of this greater coefficient of friction at that bone implant interface. So pretty exciting just when you look at the one new addition of ADAPTIS being the biofoam addition. And you go, well, where did this ADAPTIS come from? What is ADAPTIS? Why is this suddenly here? What took place over the last 10 years? Well, if you look at the ADAPTIS technology, it is the ability now to, with the introduction of 3D printing, to go ahead and allow us to place the biofoam on a variety of different types of metal implants that are 3D printed. And this followed the merger of Tournier with Wright Medical. This was basically a technology that had been available through Tournier that used on their shoulder replacements. And with the merger of Tournier and Wright, now we could take this technology and merge it with our total ankles. They were already working well, but now can work better with this porous biofoam ingrowth surface. So again, this is the ADAPTIS technology that was made available because of the merger with Tournier and the past experience with their total ankles that had this similar technology. So again, this is now based over 20 years of published experience. And again, a lot of different technologies at play here, and they're leveraging the whole 3D printing process. But again, it's going very well. And this is not just new because, again, taken from the experience that Tournier had and just merging it now with the great opportunities of total ankle arthroplasty and reconstructive surgery that Wright Medical has. So let's apply ADAPTIS now to the Infinity. So the Infinity that you know and love, now you add the ADAPTIS to it. So what are the benefits of adding all this 3D printing? Well, you're going to get this integrated porous structures. You can deal with complex geometries. You can optimize the porous substrate coverage. Our porous pegs have still a solid inner core, but now you got pores on the pegs themselves. It also has solid struts that are built into the whole monoblock or the substrate, which provide improved strength to the whole unit. So all these things are very important. When you look at the materials, it is still the cobalt chrome type of unit, but now you have the titanium porous coating over the top. How is it different than the current Infinity? So again, there's the current Infinity you know on the left, and there's the new ADAPTIS on the right. You'll see that we lengthen the posterior peg, and of course all three pegs are now coated with the biofoam material. So again, our posterior peg length has increased, and the ingrowth surfaces has been added to all the previous smooth pegs. Whereas we used to have a grit blasted on-growth surface for the old Infinity, now you have the 3D printed in-growth, not on-growth, in-growth surface design. We also have a new poly, a highly cross-linked poly we'll talk about in a few minutes. That's a big change to this ADAPTIS Infinity that was not available before. And again, with the 3D printing opportunities, we now can provide you monoblock metal components, which again will have greater bone ingrowth opportunities than the old forged plasma spray coated type of device we had in the past. As far as the new flat cut talus that's available, Infinity with Adaptus, you'll find that you can place the holder, the handle, so to say, for insertion of the talar component can be placed from either side. I used that today. It was very helpful trying to avoid impingement on the medium malleolus. I was able to go to the lateral side and able to get the end implant in much easier. We've harmonized the stem diameters. It eliminates the need for the second in-bone drilling for the central stem. Basically reduces steps, reduces the time that goes into that. You'll see that we actually, all three pegs are the same diameter, so you just drill them all the same. You don't have to go back and forth with a separate trial. And we included a shorter central stem, which not only eases the implant placement, but also minimizes any risk of subtalar joint violation in people with talar dome bone loss. And again, there's your monoblock design, which eliminates the need for back table assembly. This is all one unit. You pop it in, you don't have to worry about pounding it on the back table and getting that larger central stem in place. And then, of course, what else has changed with this Adaptus? If that's not enough, well, then you have your Everlast highly cross-linked polyethylene, something we've been looking to do for some time, but it's actually got great strength, but now it's blended with vitamin E, which has been shown to lower the risk of oxidation while not impacting the cross-linking process or its mechanical properties. So with this new Everlast type of highly cross-linked polyethylene, we can improve wear resistance up to 26% of what we saw in the past. So again, as you compare it to our legacy polyethylene, again, great ability to handle forces, but now even better. So again, this stabilizer allows the material to be stable from oxidation without remelting the material and while preserving your mechanical properties, which is so important for these poly implants that we utilize for total ankle arthroplasty. So again, just another laboratory study looking at, again, cumulative wear as far as the legacy polyethylene versus the new one, the Everlast, and you'll see that, again, does very, very well in lessening wear as you increase cycles. So we feel that this will be another wonderful addition to the Infinity with the Adaptis technology already seen. So just a quick summary now where we are. This Adaptis technology takes the successful Infinity device we've all been utilizing the last 10 years, and now you have a 3D printed porous metal component that allows for early stability, but also bone ingrowth as early as 4 weeks. That increased initial stability you'll see immediately when you put that implant in. It's a single monoblock construction, so it reduces the possibility of any delamination. It reduces a lot of just the time efforts that go into assembling the device in the back table. And then in addition, the Everlast highly cross-linked polyethylene improves wear resistance because of the infused vitamin E, but again, doesn't take away any of the mechanical properties. So all good, and you can still use Prophecy, which I do for every one of my cases. So Prophecy pre-op navigation, you all know about it, improves accuracy. Many, many studies have been in the literature showing how it does indeed improve accuracy because you're bypassing the standard extra-articular so-called instrumentation. It saves time in the OR. And again, there's been over 23,000 total ankle procedures now that have been planned with the Prophecy pre-op navigation to date. Experience matters. It does work. I find it to be extremely helpful. So just lastly, I just share with you my experience with the Infinity, utilizing the Adaptis technology over the last, I guess it's almost been 16, 17 months. So I did my first Adaptis implant, Infinity implant, in March 12th of last year. I was the second in the United States. A friend of mine in Chicago beat me to the punch, but we did our first one here in Green Bay early March of last year. Since then, I've implanted 51 of these Adaptis modifications of the Infinity. All of them have done with Prophecy. As I said, I'm a big chamfer guy, and so only 2 of these were done with the flat cut talus. My first Everlast Poly was implanted just 2 months ago, July 15th. As far as my Adaptis series to date, I've had no revisions, no failures that I know of, and I have had 2 people with delayed anterior wound healing that fortunately eventually did heal with appropriate wound care. Again, there's just a picture of the Everlast poly going into place with an Infinity with Adaptus modifications made. My technique with this Adaptus is exactly the same technique as with the original Infinity. I do make a couple little variations that you might be interested in. For the last many years, I've been using a small medial incision, as you see there on the top, to perform a posterior capsular elevation, but also, and probably more importantly, to protect the neurovascular bundle. I like to go ahead and put a retractor in the back, some kind of elevator, and you can actually go in under the posterior tib, do your posterior capsulotomy, then place a large metal instrument to then protect your neurovascular bundle when you do your bone cuts from the anterior aspect. I do a standard anterior approach to my ankle joint itself. You'll see that on the bottom right. And again, prophecy guides in place. But again, it is the same technique as the original Infinity. Both Hodges and I have always preached that we want to do a good, healthy gutter debridement, a good gutter decompression. Because of that, I always downsize my talar component. So if I use a 4 tibia, I'm going to be using a 3 talus because I do a fairly healthy gutter debridement on both the medial and lateral aspects. I do a gastric accession about 30% of the patients that I do a Infinity with Adaptus on. I do this when I have still some tight range of motion, difficulty fully dorsiflexion with even the smallest poly. So if I got the smallest poly available that fits that particular size and it's still a little tight, I usually will add a gastroc recession. So again, about 30% of my patients get a gastroc recession. Perhaps Hodges and I can also maybe talk a little bit about BMI and age, but these are things that we're looking at as well. But I'll show you very quickly a couple cases. This is my first case with ADAPTIS Technology in March of 2019. This is a 61-year-old woman. She had an old ankle injury. She had some adjacent joint issues there as well. You'll see a little osteophyte formation around both the subtalar and tanavicular joints. So I offered her the opportunity to do a total ankle arthroplasty. I thought her age and bone quality would be appropriate for Infinity. And now I had the ADAPTIS Technology available with Infinity. So we did our CT scan. I confirmed the arthritis, not only at the ankle, but the surrounding joints. I went ahead and sent them my prophecy report. It returned, says I should be using a size 4 tibia, a size 3 Infinity talus. They know me very well. This is what I typically will get from the engineers because they know I like to downsize my talus. I do usually undersize, again, because of that gutter debridement. And also, I just believe in preserving bone. So if I can use a smaller talus and preserve a little bit more talar bone, I certainly will do that as long as I have adequate coverage front to back and such. So here's the intraoperative picture of the new monoblock with the porous coating of the biofoam. And you'll see there we've implanted our device. Looks good. And here she is 14 months post-op, doing very well. Cites no pain, has good range of motion. Alignment remains very good. And so a very successful first case using this. This is my most recent case. I just did this past week. 75-year-old woman, old trauma. So you see she's had the old tibial fracture. She's got a little bit of varus. She's got bone on bone, but she also has subchondral cyst. And you'll see the CT scan there. There is a void in the distal tibia, not just a subchondral cyst. There is a large void in the distal tibia. So I basically got my CT scan. I sent it into the engineers. The engineers wrote back and said, I think maybe you should consider an in-bone tibial stem because of this central void in the distal tibia. And again, that's the advantage of having CT scan and prophecy is you can look at these things and evaluate ahead of time. But I thought, no, I think this is something I can still do with the Infinity, with the Adaptis technology. I think I can deal with that cystic change with this. And again, point of contention, perhaps a little controversial, but I elected to stay with the Infinity. I used a larger size. I worked with the engineers, used a larger size to make sure I was covering the entire cortical rim of the distal tibia. And I went ahead and grafted the distal tibia. I used the bone harvested from my resections as well as the prodents. And then I used cement on one of the areas of the distal tibia where there remained some concern about a cystic void. So again, that's how I elected to do this. It went very well. There you'll see us post-operatively. Again, this has just been 1 week, but you can see my graft material up in the distal tibia and also cement around the distal peg, particularly on that medial side where the major cyst was located. So again, my most recent case. This is one of my most interesting cases, though. I just highlight one thing I want to just share with you all. This is a 59-year-old woman, bad trauma, multiple surgeries. She's got a calcaneal malunion. She's had a prior subtalar fusion. You can see there she's lost Bowler's angle. She's bone on bone at the ankle joint level. We went ahead and got a CT scan, noted that she had indeed fused her subtalar joint. We did a fluoroscopy injection to the ankle joint, which did provide temporary relief of most of her pain. So we felt that her problem was indeed at the ankle joint level. CT scan was sent to the engineers for prophecy evaluation and guidance. But you'll see there's the CT scan. And look at that left image, and you'll see not only the malunion, but look at the amount of bone that's in that subfibular region with significant lateral wall impingement. We got the report back, size 2 tibia, size 1 infinity. Everything looked pretty good. I thought, okay, let's go for it. We did also, through the prophecy guidance, we noted that her hindfoot was indeed malaligned. She had a significant amount of lateral wall widening and displacement. But again, we thought that we had adequate talus to use to put the implant on, and we deal with the rest when we got in the operating room. Interestingly, in the operating room, I was planning on a chamfer cut, and I could not get the tailor cutting guide in despite multiple recuts. So I finally said, okay, we're going to go to the flat cut talus, did this freehand, and then use the flat talus monoblock option. You'll see that there. There's what it looks like now, all a one contained unit where you can drill your holes all at once, which certainly saves a lot of time. So again, I bailed out from the chamfer to this in the middle of the case because I just did not have enough room to get the chamfer cutting guide into proper position. Everything worked out fine. The ankle looked great. There you'll see it lined up very, very well. It moves well, excellent stability, but I still had issues with the hindfoot. Did a hindfoot alignment view. I wish it was a little bit better for you on that far left side, but it did show I still had a fair amount of bone underneath the fibula. So I went ahead and did a medial displacement calcaneal osteotomy. You'll see that alignment view there on the middle and the section in the middle, and then I used a Muck 7.0 screw to actually fix my realigned hindfoot then. But the thing I want to point out, though, is when I went back and re-reviewed my prophecy report trying to figure out why this happened, I realized that the engineers warned me that they said because of the amount of height that she had lost previously, they were going to plan for less resection of bone. And when you under-resect bone, it is difficult to get that chamfer cutting guide in proper position. So again, something I've learned from this case, and I might recommend to you that if you do see the report come back and said you've lost height, we're going to plan on under-resecting bone, you might want to just bail out immediately or plan ahead of time to do the flat cut talus rather than try the chamfer cut itself. So in summary, this has been exciting for me. I've done a lot of these infinities now with ADAPTIS Technology. It's working great. Many exciting additions to an already successful original infinity. And again, I hope this has been of interest to you. And I will now share my screen with Hodges, who can talk about his experience. Hodges, all you.
Thanks, Bob. I'm going to get you to unshare so I can put my slides up so that I can control. You know, you've known me long enough to know that I need a control. You know, it is so good to be on the same program with you. I've missed you. You've gone up to Wisconsin. I'm glad a couple of things that you still say a lot of y'alls, and so you haven't been completely Midwesternized. You also haven't gained any weight, so I'm feeling good about your diet, though I suspect that knowing you, it's mostly brown and khaki that you're eating. All right, here's a question before I get started. So if these are custom printed, how do you bail out of a chamfer cut to a flat top talus? Does it come with both? So Bob, do you want to answer that?
I'm sorry, how do I bail out?
So the implants are not custom printed. The only thing that's custom printed is the prophecy guides. What the implants are is the sizes are printed, but because of 3D printing, we're able to make everything in monoblock, including the ingrowth surface, which then changes the game because we now have something that's not centered on, it's not sprayed on, it's a one system. So the number 3 talus or the number 2 talus that you use there was a number 2 monoblock talus, and it's very easy to switch back and forth between that, and you showed that quite nicely. Comment?
Yes, exactly. No, you're absolutely right. It is. It's very interchangeable, and you're getting the same technology regardless of which implant you choose.
Okay. So Bob and I were partners for 25 years, and I can't imagine that we're not going to be partners forever. Sometime, we're at the pearly gates, Bob. Jesus, God's going to say, "All right, you go over there with Anderson because you're supposed to be together." But I was so impressed with Chris's introduction of you, and really, you've always been an overachiever, and clearly, anyone who's done over 50 total ankles with the sports practice in Green Bay is an overachiever. And I didn't realize how much an overachiever you were until I went to visit Ole Miss and found out that in 78, 79, there were 5 inductees into the Hall of Fame. And this is not the nerd Hall of Fame. This is a real Hall of Fame. Archie Manning and Eli Manning are in that. And you know what? You still have great hair, and so I love being a part of everything you're doing, and it's awesome to be back on the podium with you. I feel like we're back on it. So my role here is to try to talk about our early experience in Charlotte with Infinity with Adaptis Technology. So how's it going? To date, in the United States, this was 3 days ago, so it may have changed. We have almost 500 implanted, and this is an implant that really, the full launch is not happening until this month. So all the sets really went out this week. It has not gotten Health Canada yet, so if there are any Canadians on, but it's coming. At Ortho Carolina, as of 2 months ago, we had 20 implanted. Now it's been a few more. They're all done with Prophecy, and 5 were done with a flat cut, because one of our partners loves the flat cut and does them on all of those. And it's kind of interesting. About 50% of the United States anyway does that. Just goes with the flat cut, gives them a little more room, and they feel like it's something that'll speed that up. So the technique temps, Bob has already talked about that. Really no appreciable change in the technique. On the tibia, there's no change in the tibial broaching steps. This is a question I get a lot. You have to clear the longer peg, but it really is not a big deal to do that. It doesn't mess up the talus. And you impact with the impactor parallel to the pegs. Sometimes you have to finish with the straight tibial tray impactor, which is in the set, and that will finish and get it closer, because there's no doubt that this surface is more tacky than it normally was. But when you put it in, the stability is definitive in all types of bone, as Bob pointed out, and so it really has made a difference. On the talus, there's no change. You don't have to break the talus to get it seated. It really seats quite nicely. So this is our patient Alpha in Charlotte. 72-year-old, history of an ankle fracture 35 years before, a classic post-traumatic, severe disabling ankle pain with some valgus in the collapse. Here is the CT scan, and you can see that the hardware is going to be a problem, but again, fairly straightforward as these go. You can see you had to take the tibial hardware out. This is the first post-op visit. And this is 18 months post-op with full activity. And what I love to see in these is you can see the on-growth, the ingrowth, not the on-growth. You really can see it. And we used to see this with Biofoam, still do with Biofoam. And we know that the ingrowth has happened, and the initial stability, as well as what we're seeing almost at 2 years, is really quite impressive. Here's a 49-year-old who had multiple surgeries. And the last one was a subchondroplasty, not unusual that we're seeing some of these that we're having to go back and do something with. You can see the subchondroplasty material on the medial side of the talus. And this is one that we on purpose did a flat cut using the old flat cut. This is at first post-op visit, and this is at 9 months. And you can see the ingrowth on the tibia is dramatic. And that's kind of what we've been seeing. This is Aaron Mates, who did the first block talus in the United States, and this patient is now about 6 months out. I would tell you though that when you're talking about total ankles, that implant choice is a cautionary tale. And as we've gone through this process, and Bob and I have been part of a very active ankle design group, we really felt like all of these implants fit into the continuum of care that the complex patients with ankle arthritis need. Prophecy, I think, is essential for so many things. The Infinity with the chamfer cut, the Infinity with the flat cut or the block talus, in-bone, and Bob and I have been doing in-bone for 10 years plus, in-bone 2 anyway, in-bone for close to 14 years, and then Envision, which is really the first and only truly modular revision system that is present. And in my practice, I use every one of these options, and I mold what is needed to the patient by using the implant that is needed. So we know the Infinity story is articulating surface, correct axis, all those things. Our goal was precision with reproducibility, stable fixation, longevity. We wanted like the total knee, and we wanted to use it for some complex deformities, but our goal was never to eliminate in-bone. In addition, we really believe and continue to believe that a well-executed 2-piece total ankle was better than a 3-piece design. We have no backside wear. We get great coronal stability with the exaggerated sagittal sulcus, and we're not seeing the early osteolysis that some of the 3-parts saw. So we thought there were theoretical advantages of resurfacing, and we also felt that there was increased salvageability in some of these, both in the tibia and the talus. So the new system was going to be a complement to in-bone, not to replace in-bone. So all of these goals were important, but we needed the system to be in-bone compatible. And so with experience, we're dividing the ankles that are best for Infinity and for in-bone as a primary. Both systems, in my opinion, are essential to handle the challenges of this difficult patient population. Infinity is ideal for maybe even the majority of the end-stage ankle arthritis challenges, as Bob has shown, but I would recommend don't give up your in-bone, and I'll get Bob's comments on that when we move forward with this. And these are the lessons learned. This is a patient, actually, Bob, I think it was one that you and I shared, a 72-year-old, gave a varus foot, varus degenerative ankle. He's a tall, big guy, and he's mildly neuropathic, right? And I really do believe there is mildly neuropathic. It's not like being kind of pregnant. We see these patients that have a little neuropathy, but severe pain that mirrors what we normally know in these patients. So we did the foot first, fixed the varus heel, and then 8 months later did an uncomplicated prophecy Infinity. At the first post-op visit, everything's looking good. At 5 months post-op, he collapsed and developed a medial malfracture. We ended up doing a 2-part staged revision, and he has an Envision in the tibia and an in-bone in the talus. He's now 3.5 years out and doing fine. And this is one of those patients where I go, what did we miss? And I think we missed a few things. And so ultimately, in my practice now, with a high level of deformity in my practice, I'm doing about 100 a year, and I'm doing half in-bone and half Infinity. So my Infinity patients are young, they're low to moderate deformity, they're less stiff, and they have no neuropathy. And when I'm saying no neuropathy, I mean that. Infinity with the in-bone flat cut talus is patients that have a flat talus already that are stiffer, like Bob showed. I mean, if you change the height, you may have to go to a flat top talus. Complex deformities of the tibia and hardware challenges. In bone, I use it older, softer patients. I use it in my obese patients, and in particular in the mildly neuropathic patients with bigger deformity, stiffness, also who have severe hindfoot fusions, and I use them for some revisions. In vision for primaries, I use the tibia for a primary with severe bone loss and poor bone quality, and the talus for primary that has poor bone. And sometimes I use it for two stagers that I do a hindfoot fusion first. So Prophecy Infinity, young, low deformity, less stiff, no hint of neuropathy. So 63-year-old, youngish. Anyone who's close to my age is getting real young, post-traumatic, and used in Infinity with Adaptis Technology and Prophecy first post-op. And here it is at 1 year, doing great. No evidence of subsidence, loosening, and pain-free. Infinity with flat top talus. Which ones do we do those? This one is varus, is stiff, and has significant disabling ankle pain with no neuropathy. And you can see how the talus is flat top. And so doing a chamfer talus, you might notch the talar neck. So here's the Prophecy, and the Prophecy works great with the flat cut talus. And here's what it looks like in bone talus, more room, didn't notch the talus. I could be super aggressive with the gutters because I had a little more room, and the deformity is corrected. Some people say that this speeds up the process. For me, doing a flat talus versus a chamfer talus only adds about 5 minutes. Here's a history of recurrent ankle sprains in a 62-year-old. You can see that posterior subluxation is not that big a deal, though most of these folks require either a gastroc or a TAL, super stiff. And this is one we went with an Infinity tibia and a flat talus. So here's him at 7 months post-op, and you can see how the tibia has ingrowth beautifully, and the deformity pre-op has gone away with excellent gutter debris mods. What about complex deformity? Here's a 69-year-old, history of open tib fib, treated with a rush rod in the fibula, 5 years of progressive pain. Is this pain? Can we do this in one operation? Prophecy is extremely helpful with that. So I sent in a Prophecy report, and I said, I want to put this in on the mechanical axis. And they said, sure, you can do that. And this is what the Prophecy report showed. And in fact, it was not that hard to do. Compared to plan, worked out beautifully. And she is now 4 years out, not living in our area, so I don't have any standing films. What about in-bone? Mildly neuropathic, older, softer patients with big deformity. 59-year-old with a significant varus has already failed a reconstruction that includes a calcaneal osteotomy and a lateral ligament reconstruction. And you can see here, we were able to fix it in a single stage and did a dorsiflexion osteotomy of the first. What about Envision as a primary? I use it in the tibia for bone loss and the talus for poor bone. I also am trending to use Envision in patients that I do these big first reconstructions to get the foot out of valgus. So I've done a double with a MDCO and a Lapidus. I've got the Mary's line great. These patients I'm cutting a little lower and doing an Envision talus because I think it protects me from AVN. This 59-year-old, 6 years status post to trimal. CT scan shows severe tibial bone loss. 2 years post used an Envision tibia. I protected the medial mal because that was super concerning on the CAT scan. Flat in-bone talus. Here on the talus, 59-year-old, history of RA. You can see how bad the talar bone is. This is one that I'll opt to go a little lower on the talus and use an Envision talus. And you can see how nicely the Envision talus does with excellent fixation in the more distal part of the tail or neck and body. So my conclusion is Infinity shows excellent early results. It is my belief that Adaptis Technology will expand on this and will be a massive game changer. In my opinion, comparable or better than previous mobile bearing designs that I've seen both in my experience as well as in the revisions that I'm doing. In my opinion, all of this technology is encouraging for ongoing use and further study. So far, our early feedback has been great. As I said, over 475 cases. Scott Ellis says Infinity even better than before. Dr. Vora says this robust prosthetic bone interface ingrowth results in improved initial and long-term implant stability. John Lewis in Louisville says the initial component fixation and stability followed by predictable bony ingrowth into the prosthesis is a game changer. So improved long-term fixation, increased initial stability, and improved wear resistance. All right, Bob, any comments?
No, that was great, Hodges. And I agree completely that you don't want to use Infinity, even with the Adaptis technology, for all comers. You really have to think about all the other variables. And I completely agree with you. If I got somebody with poor bone quality or really bad rigid varus or valgus deformity, or somebody who just, revision situation, I'll go to the in-bone, or I'll go to the in-bone with an envisioned talus. And so I think that you really do have to understand all the nuances and not just get stuck in the thought process that everybody's going to get an Infinity type device. I am intrigued by what is mild neuropathy. I do obtain a nerve conduction study on patients with diabetes who I'm concerned about some paresthesia issues, some loss of sensation. And I have not been doing total ankles on anybody with a polysensory, type neuropathy with a, basically a concern where they have a neuropathy. I don't know what you define as mild. I basically have find if they've got neuropathy, a symmetric, sensory motor neuropathy on that neurologic study, I typically will not offer them a total ankle. On the other hand, I just had a guy who because of that, I did an ankle fusion. He went on to a non-union. So, who knows what's better, but I'd be interested in what you think about mild neuropathy. Also, the other thing is I have not yet found where BMI is a threshold. I have been doing up here. There are a lot of large individuals and higher BMIs, and I have not found that to be a deterrent to doing even the Infinity. Maybe I should be doing more in-bones in the more obese people. Same with age. I did an 82-year-old, I did an in-bone last week. On the other hand, I've got 75-year-olds, I might still do Infinity. So those three things real quickly. What is mild neuropathy? Do you have a BMI threshold? And what about age?
So, I do neuroconduction studies also, but Bob, you'd be so proud of me. I walk around with monofilament testers in my lab coat, and you can order them on Amazon, and you can get a whole bag of them for about $5. And so I do monofilament testing, and if the monofilament testing is negative, meaning you know what a negative is, 5.01, like we taught for so long in the complete foot care course, then those are patients that, in my opinion, have mild neuropathy but still have protective sensation. And those patients, I will do an ankle replacement. If they fail that, I'm doing a fusion, and I'm not hesitant to do a tibio-talar calcaneal fusion in those patients, because as you know, those things can fall apart quickly. The second piece in older patients is I find that that in-bone even has better initial stability. Now, I may make the shift back as I get more and more confidence with my Adaptis patients, but I am still using, if I have someone that I know their bones can be a little soft, I just go straight to in bone, and it for me that works. I know I can move forward. I can walk them very early, and I think the morbidity on these folks is less. The other piece, which may or may not mean anything, is with in bone I can do a smaller incision because the cut guide is up top, and so in those patients I'm still trending towards in bone. I may change, and seeing your patients and what you've done with Infinity, I think is great, and that's the way it is. All right, I just got no, not 5.01, 5.07. Bob, you should have corrected me.
Yeah, and what about BMI?
So the ones that I immediately go to in bone on are the ones that have mild neuropathy, and so if they've got some mild neuropathy and they're big, I go to in bone on 100% of those. So but if they're just obese with not a bunch of deformity, I still would do Infinity on those folks. And
Okay.
I really think Adaptus has changed because they grow in quickly. I do protect all of my total ankles in a boot till about 7 or 8 weeks, and I think that allows for ingrowth. It allows for nice stability, and it also calms down the soft tissues. You know, Bob, you were the one who taught me how much casting and booting can kind of calm the soft tissues down, and I think that they feel better when they get to physical therapy at the 6 to 8 week mark.
Yeah, I was going to say too, Hodge, just talking briefly about post-op management, because so many people want to know what we're doing post-op these days, is pretty much I assess the wounds at 2 weeks, and for the most part, I'll put people back in a cast for another 2 weeks, keep them down weight bearing until 4, and then I let them weight bear in a boot for 4 weeks, then pretty much out of the boot by 8 weeks into a shoe and start physical therapy. So, I mean, that's a very general look at it, but I don't know what your plan is now, but generally speaking, I'm walking at 4 weeks and into a shoe by 8.
That's exactly where I am. Exactly where I am. And I just find every time I try to get them out of the boot earlier, I think they struggle with swelling. And the nice thing is I can get them in a compression sock while they're in the boot. I'm exactly the same, and I don't mind slowing them down a little bit, but it makes a big difference in an 80-year-old to be able to put weight on it early. I mean, it does, and they're patient with the wounds, but putting an 80-year-old on crutches is something I try not to do. And I know, Bob, you love doing external fixator frames so much that I could see you just sticking them in an external fixator frame.
So the only other comment I was going to make, I meant to do it in a slide form, was talking about my Infinity, and it's true for in-bone and other total ankles in vision, is how often I actually add a dorsiflexion osteotomy of the first metatarsal when I'm correcting a varus deformity. And I just think that everybody should be ready for that. Always have that on the back of your mind if you're correcting a varus deformity, whether you're doing it with the Infinity or in bone, that always be prepared to add that at the end of the case. I had a good example of that today. So again, I would say that the vast majority of people I'm correcting a varus deformity at the ankle, I am adding a dorsiflexion osteotomy. I don't know if that's been your experience as well.
Absolutely, and I'm fixing them a little different just because I want to get them walking. I used to use a compression staple. Now I either use a nitinol staple or do an oblique osteotomy and use a screw. I'm doing some MIS dorsiflexion osteotomies, playing around with that, and that speeds up the healing process for sure. Okay, Chris, we're right at 7. We said we had a hard stop. Do you have a few final words, and then we'll call it an evening?
Yeah, definitely. So Bob, Hodges, thanks so much for taking the time this evening. I mean, just the discussion around patient selection, around the new technology, around your algorithms for care was awesome. And just thanks to everyone else that's out there I really appreciate you joining us tonight. We hope that you found this webinar beneficial and that you're as excited about this new technology as we are. So if you'd like to learn a little bit more about Infinity with Adaptus, please reach out to your local Wright Medical sales team or feel free to visit us at wright.com. We'll also have this posted up on our virtual learning center, which is wrightmeded.com. So feel free to join there. And then throughout the course of the end of the year, we're going to have a bunch of additional webinars and a variety of innovative topics out of Wright Medical. So feel free to join one of those if one of those piques your interest. So thanks again, and have a great evening. Thanks, everyone.